Okay, next up, we have Dr. Robert Coghill. He's the director of the Pediatric Pain Research Center and a professor in the Division of Behavioral Medicine and Clinical Psychology at Cincinnati's Children's Hospital. Dr. Coghill's research interleaves data obtained with functional MRI of brain activity with subjective reports of pain and psychological state. He's highly interested in understanding how the nervous system evaluates and constructs an experience of sensory components of pain, including perceived intensity and location. Dr. Coghill also seeks to develop better tools for the measurement of multiple dimensions of the pain experience. So please welcome Dr. Coghill.
Yeah, thanks so much for that lovely introduction, and thanks very much for Rajam for inviting me to this, because I've heard about it year after year, and I'm really, really excited to be here. So it's been a blast so far. And even though I'm really excited to be here, I'm really frustrated. I'm really frustrated because I've been doing pain. I started doing pain research as a summer student in 1983, and the advances that I've seen, I'm a pure researcher. The advances that I've seen in the translation of those advances into clinical care has been virtually nil. And that's really, really frustrating for me. It's like, you just go, what are we doing, and why can't we do something about pain? Why can't we do something better for pain? And I think one of the things that we really need is we really need a new framework for understanding pain. Like, sort of right now, the patients really suffer tremendously from dismissal of their symptoms and uncertainty about their diagnoses, because we don't really have the tools to provide clear indices of the nervous system disruptions that are giving rise to their pain. And a lot of the current approaches to pain are really very reductionistic, especially a lot of the research is framed in that way. It's like single molecules, single neurons, and single brain regions. And people are really not putting that together very well. And this sort of very reductionistic type approach really fails to provide adequate explanations for patients' symptoms of pain, and it's really unfortunate at basically developing new treatments for pain and or especially implementing the ones that we already have that actually work fairly well. So some of these aspects of pain that are very difficult to understand through the conventional lens, one of the big ones that I've been fascinated with for, since my earliest research is the spread of chronic pain and how chronic pain can spread. And this is a study by, I don't know if I have a pointer or not here, by Van Ryn et al. That shows that with patients with complex regional pain syndrome, basically the longer their pain goes on, a huge proportion of them will have a contralateral spread of their chronic pain. Others will have an ipsilateral spread of their chronic pain. And in working with the pain clinic at Cincinnati Children's, we see routinely kids with CRPS that have pain in three out of 4 limbs from a unilateral injury. So that spread of pain is very, very common. But the neural mechanisms to explain that are really, really murky. People are not really looking at those types of questions. And another aspect of pain is the really massively disappointing limits of pharmacologic therapy for chronic pain, for neuropathic pain. And this is taken from a paper by Nana Finnerup looking at the numbers needed to treat of numbers of neuropathic pain patients needed to treat to typically get like a 25% or maybe a 50% reduction in pain, and looking at all the clinical trials over time. And some of the best drugs like gabapentin, pregabalin, have numbers needed to treat of 8. And I mean, that's just really terrible. Like 1 out of 8 patients is responding to this drug in a way that's actually going to be clinically efficacious. And, I think it is because we're thinking in a very reductionistic fashion of single drug, single neuron, single treatment type thing. And Then another aspect of pain that's, I think, also very poorly understood is how pain can be so resilient. And this is a really, really old case that I stumbled across in Nordenboss's classic book on pain from the late 50s, I think. It was sort of the predecessor almost to the gate control theory. And I tracked down one of the papers that he cited. And he had a patient with he was talking about a patient with postherpetic neuralgia. And this poor patient ended up in the hands of a fairly aggressive neurosurgeon. So they started to basically work on the peripheral nerve to try and block his pain. That didn't work. They irradiated the trigeminal ganglion. They cut the sensory root of the trigeminal nerve. They started doing nerve blocks. Nothing fixed his pain. They cut out the contralateral portion of the somatosensory cortex for his face. That didn't fix his pain. They cut out the ipsilateral portion of the sensory cortex for his face. That didn't fix the pain. He got ECT, and then he got a bilateral prefrontal lobotomy. And that still didn't stop his pain, although it wasn't quite as troublesome as it had been. So, this shows like how resilient that system is. So what I want to talk to you today is maybe a new way forward. So this is based on a paper that I published in Trends in Neuroscience. So combining two ideas of population coding and distributed processing into this model, this framework that we're calling the Distributed Nociceptive System. And so there's going to be a lot of talk about neurons, so don't run out and scream or throw things at me. But I think the two big things to take away from this in a real simple way is that pain is encoded, nociception, I should say, nociceptive information is encoded by populations of neurons working together. So that's one of the really key aspects of this model. Like populations of neurons are working together to encode nociceptive information. And then as this information moves centrally, it is processed in a very distributed fashion. So multiple parallel mechanisms are involved in the processing of this information. So if you can take home those two messages, that'll be great. And if your eyes glaze over when I start talking about receptive fields, that is totally cool. So what I'll start to talk about first is population coding, neuron recruitment, and distributed processing in the spinal cord. So this is sort of a conceptual redrawing of some data that Don Price collected back in 1978. And Don was one of my mentors for sure, and I think this paper, in this 1978 paper, that encapsulates so much of what is important about the neurophysiology of pain, and it's still a brilliant paper. And so one of the things that Don did is he mapped out the receptive fields of one of the two types of nociceptive neurons. So they're nociceptive specific neurons and they're wide dynamic range neurons. Wide dynamic range neurons were named after the stereo equipment of the time that could reproduce a wide dynamic range of sounds. And these neurons have receptive field gradients. So if you look at the receptive field of neuron number 3, you can see that it's got a central receptive field zone in bright red, and then a peripheral receptive field zone in orange fading to yellow. And with the wide dynamic range neuron, these neurons respond to both noxious and innocuous stimuli. So if you basically did a light touch on that toe for neuron 3, that neuron would be activated, but neurons whose other receptive field zones, the peripheral receptive field zones, are not encompassing that area, won't be activated. Then, in turn, if you deliver a mildly noxious stimulus, you'll recruit that neuron, but then you'll also recruit neurons 2 and 3 whose peripheral receptive field zones start to extend into that area. And then if you deliver a really strongly noxious stimulus, you'll recruit neurons whose even greater peripheral receptive field zones that are even less sensitive and take more stimulus intensity to activate will also be recruited. So Don basically really came up with this idea of population coding. And I got a very, very early start in neuroimaging. I actually started in rats with autoradiography. And what we would do is we would have a spinal cord transected rat and look at glucose metabolism as an index of activity using the 2-deoxy-glucose model. And what we see is, if we look in the leftmost column, you see that the 35 degrees Celsius stimulus is not producing any activity. We're immersing the rat's hind paw in various temperatures of water. At 43 degrees Celsius, at 45 degrees Celsius, you see some very focal activation in L4, the fourth lumbar segment. That's sort of the epicenter of where the foot is represented in the spinal cord in the rat. And then as we go up to 49 degrees, you see that we recruit a lot more neural activity. That neural activity is significantly increased over multiple spinal cord segments, statistically activated from L2 all the way through L5. And then also there's some, and I have to switch from the brain, there's also some contralateral activation that you wouldn't normally expect. So this information at the level of the spinal cord is starting to go bilateral, and with an acute nociceptive stimulus. And then my fellow grad student at the time, Jenren Mao, extended this into a rat model of neuropathic pain. And what he found is that in the unilateral nerve injury, there was this extensive rostrocaudal spread, rostrocaudal recruitment of activity, but then there was also this contralateral engagement of activity that was present during the chronic constriction injury. And these neurons in the deep dorsal horn and even lamina 7, we tend to think of lamina 7 as like a motor area, as a ventral horn, but many neurons in lamina 7 also project up to the brain, and many of them also have bilateral receptive fields. So one of the questions is, how is this information being spread across the spinal cord? And I am really not an anatomist, so going through the old anatomy literature was really tough for me. And also, too, our library had all the stuff on it, didn't have it in stock, so I had to get it like from interlibrary loan, so it was really a slow process. But, so when primary afferents come into the spinal cord, they arborize, and they can send projections multiple spinal cord level, multiple spinal cord segments, rostrally and caudally. So, we're taught all this stuff about dermatomes, but then once you get into the central nervous system, those dermatomal boundaries become much more of a continuum. And so we can see, if we look at the red arrow, we've got an activated nociceptor, and you can see that nociceptor is arborizing and spreading across multiple spinal cord segments in the superficial dorsal horn. The classic way that there's an orange neuron A, which is over there. So the orange neuron A is basically sort of the classic pathway. So the nociceptor is coming in, synapsing on that neuron is projecting up to the brain. And that's occurring in the same spinal cord segment. Excuse me. Okay. But then we also have neuron B, which is sort of in the center of the drawing, a little hard to see, that is maybe at the extent, at the rostralmost extent of that primary afferent. So that primary afferent is also synapsing on that neuron, and then it's synapsing on this green neuron that's a propriospinal interneuron. Now, propriospinal interneurons are neurons that start and end in the spinal cord, and they can connect the forelimb with the hind limb, and they can connect contralaterally. So they can connect the ipsilateral part of the spinal cord that's receiving information with the contralateral part of the spinal cord. So here we have an architecture that can drive neuron recruitment and can basically start to explain how nociceptive information can spread on the same side of the body and can spread to the opposite side of the body. Now, one of the corollaries and one of the predictions that you would make from a population coding model would be that you would have spatial summation of pain. And I think I might have been in this study as an undergrad or grad student. So this is another study that Don did, where he had 3 heat probes that he placed on the forearm and would activate different combinations of them when they were separated by 0, 5, or 10 centimeters. And what he found was that basically pain would summate a great deal. It's sub-additive, which is interesting. And we don't tend to talk about that as much as maybe we should, but still pain is summating. So 2 stimuli are causing more pain than 1 stimulus alone. And given that and we found that this summation can occur over multiple dermatomes. We've seen summation, I think, over 6 or 7 dermatomes. So again, those dermatomal boundaries break down and become more of a continuum. And also, you can recruit more stimuli or going to recruit more neurons. Now, one of the things that's really important in this population coding model is the receptive field architecture and how those receptive fields can change over time. And so receptive fields can be regulated both in a bottom-up way and in a top-down way. And this is a really cool study done by Ole Anderson's group in Aalborg, where they mapped reflex receptive fields. And they did this in a spinal cord transected individual, so there's no information flowing down, and they're mapping which muscles basically respond to stimuli on different parts of the sole of the foot. And they delivered an injection of capsaicin to the sole of the foot and found that the reflex receptive fields expanded tremendously. So here we've got this dynamic change that's caused by this super intense stimulus. And again, the stimulus isn't being perceived because the individual's got a complete spinal cord transection. But the neurons are still expanding their receptive fields. And what that's going to mean is once those receptive fields expand, more and more information is going to be recruited. Now, in terms of some top-down regulation of receptive field size, there's been very, very little work on it. But one of the early studies that was done by Ron Hayes at NIH, a monkey study, they basically mapped out a neuron in the monkey's face, and they trained the monkey to attend to stimuli. And what they found was when they told the monkey to attend to a stimulus contralateral on its face, that receptive field actually expanded, crossed the midline, and started collecting information from the opposite side of where it should have been doing it. So we played around a bit with regulation of spatial filtering of pain. And we started out with doing this with a grad student of mine, Alex Quevedo. And this was a great one because it was a result of a really puzzling sort of rotation project. And this guy's new in my lab, and he's really gung-ho, and got this really puzzling result of where we did a study and didn't get spatial summation. I'm like, Alex, everybody gets spatial summation. Something's not right here. Go and replicate what you did on the leg or on the arm, And he replicated what he did, and he kept saying, I think it's attention. I think it's attention. I was like, Alex, that stuff's like probably all hardwired. The receptive fields are going to be sort of fixed. I don't think attention's going to do anything. But he's like, can I just do a pilot study? I'm like, okay, here's $1,000. Run off and do a pilot study. So Alex goes and does a pilot study that was published in the Journal of Neuroscience, N of 10. And what he did was he had people rate pain under 2 conditions in a spatial summation paradigm. So he had healthy volunteers give overall ratings by giving just 1 rating of the 2 stimuli that were active, and he had them give 2 ratings, separate ratings, 1 for the proximal stimulus and 1 for the distal stimulus. And what he found, to my tremendous surprise, was that this attentional set we saw spatial summation of pain. So if you compare the far right bar with the second bar, we saw spatial summation of pain. That worked out quite well. And then when he had people divide their attention, it abolished spatial summation of pain, and in fact, at the proximal site, produced an actual inhibition. So what we think is going on at a real mechanistic level is that we really started to think about spatial tuning. So how these neurons' receptive fields are configured, and then configured dynamically to collect information in a very different fashion. So what we proposed is that this attentional set would turn on some inhibitory processes that might very well be surround inhibition. And in doing that, turning on the surround inhibition is going to sharpen the receptive fields, reduce the extent of the body that they cover, and it's going to minimize the interactions between the two stimuli. So we're currently exploring this paradigm in patients with chronic pain, and we'll be really, really interested to see how does their ability to regulate spatial summation of pain relate to their spread of pain, for example. So I think, with a lot of these population models, when you start to think about populations of neurons and their complex receptive fields and their dynamic regulation of receptive fields, that can start to provide an explanation for why some types of pain, I think specifically complex regional pain, have been documented to spread quite extensively. So that would be maybe one mystery that we can start to better unravel with this foundation. So next what I'm going to do is jump up to the brain and talk about distributed processing. And so then, how is this incoming nociceptive information processed within the brain? And you typically have your textbook figure is like one neuron in the spinal cord, one neuron in the periphery goes to one neuron in the spinal cord, and that neuron goes up to the VPL in the thalamus, and then that neuron goes to S1, end of story. Well, that story is a lot more complicated. And so one of the things, again, with this deep dive into the really old anatomic literature that was just excruciating, I am so a physiologist and not an anatomist. Even though I spent 16 years in an anatomy department, that's a supreme irony of my life. My brain does not work with that stuff. But within the spinal cord, there are multiple different populations of neurons and multiple different laminae. And there are direct spinal projections to thalamic nuclei, such as the VPL, the VPI, and that would be the ventroposterior lateral nucleus, the ventroposterior inferior nucleus, the posterior nucleus and suprageniculate nucleus, and the medial dorsal nucleus, and then a separate nucleus, the parabrachial nucleus, and then even direct projections from the spinal cord to the amygdala. And then in turn, all of those areas, VPL projects predominantly to the primary somatosensory cortex. VPI projects predominantly to the secondary somatosensory cortex. The posterior nucleus and suprageniculate nucleus project to the posterior insula. The medial dorsal nucleus projects to the anterior cingulate cortex, and the parabrachial nucleus projects to the amygdala. So now we've got multiple parallel pathways for this information to flow forward. And then when you start to look at the interconnections between these areas are all really, really highly interconnected. And David Friedman, an anatomist who actually happened to be at Wake Forest, I ended up co-teaching medical school with him, really mapped out this pathway going from the primary somatosensory cortex to the secondary somatosensory cortex through the insula and onto the amygdala. So that was mapped out anatomically in the mid-'80s. And at that point in time, we really didn't know what was going on at all with the insula. But so we have an architecture, we have a neuroanatomic architecture that can spread nociceptive information in parallel to multiple different cerebral cortical areas. And so in '94, when I was doing my postdoc with Gary Duncan and Kathy Bushnell, we did one of the very, very early functional imaging studies, and we found activation in the insula. But we found activation that was related to pain in multiple brain regions. And we basically introduced the concept of distributed processing in that paper. And we saw activation in S1, S2, the insula, which took a long time to figure out, and then the anterior cingulate cortex as well. And I think one of the key components of this distributed processing situation, this distributed processing arrangement, is that the information processing needs to be basically degenerate. So it needs to be a really simple signal in order to be processed in a very distributed fashion. So this is in sharp contrast to maybe the very hierarchical processing that the visual cortex, or that vision basically engages, of where different brain regions are extracting all kinds of different features, edges and colors and everything, and it's an incredibly hierarchical process. What we see for the nociceptive system is, again, it's very distributed, it's very parallel, and it doesn't have that same degree of hierarchy that the visual system for sure would have. And what we see when we look at stimulus-response relationships, we see stimulus-response relationships very classically in the primary somatosensory cortex. That's what you would expect. We also see stimulus-response relationships in the secondary somatosensory cortex. And here we can see that information processing in S2 has gone bilateral in these healthy participants as stimulus intensity increases. And we also see stimulus-response relationships in areas that might be more related to affective processing or more cognitive type processes, such as the anterior cingulate cortex and anterior insular cortex. And we also see an inverse relationship in the posterior cingulate and precuneus, and those are areas that are thought to be involved with default mode processing. So what we have is we've got stimulus intensity related information that is widely distributed, almost certainly in parallel, or the capacity is there for parallel transmission to these multiple different cerebral cortical areas. And then this gives rise to the possibility that the notion of multiple realizability. So I think looking at the brain lesion evidence, it's very clear that pain can survive multiple different brain lesions, and as such, the experience of pain can be realized, can be reified, I guess, can be brought into an actual experience using many different patterns of brain activity. And some examples of this would be a study that Don Price did with Barry Stein and Mike Kazaniga, looking at pain processing in a person with a split brain, where the corpus callosum had been transected to control epilepsy. And at low noxious stimulus intensities, only the contralateral hemisphere could report the intensity of pain. However, once the stimulus intensities got relatively strong, 49, 51 degrees, both hemispheres were reporting intensity almost equally. So that information was crossing bilateral at a level below the cortex because it can't get through, the corpus callosum was cut. So it had to be crossing the midline at the thalamus or even lower levels, possibly even the spinal cord. There was a study by Nett et al. That came out looking at lesions of the primary somatosensory cortex, and these patients basically had major and significant tactile deficits, but had almost zero deficits with nociceptive processing. Another study that Karen Davis did was a patient with obsessive compulsive disorder who had a cingulotomy, where the cingulum bundle was burned out by a lesion to control the severe OCD. And what happened there when the cingulate cortex, the adjacent cingulate cortex, and the cingulate bundle were damaged, instead of reporting less pain, which is what you would predict based on the very, very old literature, this patient was actually more sensitive to pain and was actually disinhibited. One of my grad students, Chris Starr, did a really nice study of patients with lesions of the insular cortex, and basically we found the same thing, is when the insula was blown out by a stroke, we found that these individuals who didn't have central pain were far more sensitive to pain on their affected side than on their unaffected side. And the activation that we saw in the primary somatosensory cortex mirrored that sensitivity. So it was like almost the primary somatosensory cortex was disinhibited by loss of input that would be coming through the insula. And that might be some contextual input, some memory, some instructions and everything that just didn't get to the processing mechanism. And as Tim Solomons talked about yesterday, it's a paper that I love to talk about. Is you got to see the video of the patient that had these really extensive lesions that took out the amygdala, insula, and primary somatosensory, not primary somatosensory cortex, but cingulate cortex. And again, pain in that individual was quite well preserved. And then a study that Håkan Olsen did with Catherine Bushnell looked at patients with hemispherectomies, where they had had one whole hemisphere of their brain removed for control of epilepsy, and they could still perceive pain contralateral to their missing hemisphere. Get that right. So they could still perceive pain on the side where the hemisphere was, should be subserving and was gone. So that would be consistent also with the split brain data. So then this raises a possibility that I think all this taken together is that not even raises a possibility, I think it indicates that the subjective experience of pain can be instantiated by multiple different mechanisms. And that might be why it's so very, very difficult to disrupt. And we did a study looking at individual differences back in 2003, saw a very nice relationship between perceived pain intensity and brain activation. We only had 12 subjects. We decided to replicate this. It took forever to get the grant funded to do it. We like 10 tries. We finally got the grant, we finally got the data, or finally got the funding, and then we ran out and collected data from over 100 participants. And what we found was beautiful stimulus-response relationships within individuals. And then when we looked across individuals, we had this tremendous range of individual differences in sensitivity. People went from just barely above 0 to almost 10 on our visual analog scale. And when we looked across those individuals, we saw absolutely no signal whatsoever related to individual differences in pain. And that just really, having done brain imaging for, 30 years, that really upset the apple cart for me and really made me think differently. And there are a couple possibilities as to how this might be going on. One possibility that's been put forward in one of the critiques to our papers, at least, so I'll use that, it's convenient, is that there is that multiple realizability of where the experience of pain is being instantiated in very different networks of brain regions, and when we lump across all individuals, we can't see it. The other possibility is we're using blood oxygenation level dependent contrast, or the BOLD effect, and maybe there's some metabolic difference or something of where BOLD is very sensitive. BOLD seems to be very, very sensitive to within subjects effects that are related to nociceptive processing. And maybe the processing of pain is not engaging that blood flow change to the way that we would very easily predict based on nociceptive processing. So why this is happening, it's definitely a mystery, but it's a shocker. And we put this through the ringer in I mean, it took us a couple of years of control analyses to convince ourselves that it was real. And then the reviewers actually managed to find a whole bunch of stuff that we hadn't thought of. And we went and did that again. And after 3 rounds of review, we finally got it out in Nature Communications. So my postdoc, Marie-Eve Opley, deserves a huge amount of credit for that, because this is one of the most difficult studies that the lab has ever had to deal with. So anyway, with this information being very widely distributed, we need to think about how do we better treat pain. And knowing what we know about population recruitment and knowing what we know about how pain is distributed. And my colleague at Cincinnati Children's, Ann Lynch Jordan, looked at data from multi-disciplinary chronic pain clinic in kids and looked at the relationship between disability and perceived pain intensity. And this graph is a little hard to follow, so I would say just look up to about session 5, because what happens is the numbers start to drop off and it's statistically valid, but it's harder to see. So if you look up to, from session 1 to session 5, you see disability is really dropping very rapidly with multidisciplinary therapy. That would be psychological therapy, physical therapy, as well as medical therapy, whereas the pain intensity ratings are staying relatively flat. So what this, I think, does a nice job of proving is that function actually improves before pain intensity does. And I'm a sensory neurophysiologist, and that really shook up the way that I thought, because I'm thinking in maybe a fairly linear fashion of pain intensity drives pain unpleasantness, and maybe pain unpleasantness is starting to drive pain-related disability. And what she showed in this study is that function is recovering before pain intensity does, and then pain intensity is following the recovery of function. And when you start to think about it, again, from this complex network that's involved in the processing of nociceptive information and or pain, you can see that it really needs multiple ways of controlling it. And so we did a study in headache looking at one sort of maybe complex way of reducing pain, which would be looking at reduction in headache days following cognitive behavioral therapy. This was done by my postdoc, Hadass Naman in collaboration with our headache collaborators, Andrew Hershey and Scott Powers. And with cognitive behavioral therapy, we saw about a 33% reduction in the number of migraine days per month. And we imaged these kids before and after. And what we saw was in all the kids that experienced CBT, we saw changes in the functional connectivity of the amygdala. So the insula and the anterior cingulate both exhibited sort of increased connectivity with the amygdala over the time that they had CBT. And then the individuals who had the greatest response to CBT had actually the greatest reduction in other areas, different parts of the anterior cingulate cortex. And then when we looked at the ability to predict who was going to respond to CBT, we see that other brain areas could actually predict who was going to respond to CBT. And those would be parts of the primary somatosensory cortex, cingulate cortex, and prefrontal cortex. So here with CBT, we've got a treatment that is engaging multiple different brain mechanisms that can counter the effects of the multiple different brain mechanisms that are engaged during chronic pain, or during pain in general, both acute and chronic. So we've got a ton of studies that are going on. We're looking at all different types of chronic pain patients, and really trying to understand, can we use some of these signals to better help with diagnoses and to better predict treatment efficacy. So finally, I'd like to wrap up with sort of leave you with the notion that neuropopulation recruitment can provide a substrate for the spread of pain away from the area that's been directly affected to unaffected regions. And then distributed processing at both the spinal cord level and supraspinal regions can produce a system that is very, very resilient to disruption. And that we need, because the system is so distributed, we don't need a pinpoint reductionistic type treatment. We need a very holistic treatment that is going to basically target multiple brain regions and spinal cord regions simultaneously, and multiple combined therapies too. And I think that's where, you know, the multidisciplinary pain clinic comes in: pharmacologic therapy, physical therapy, occupational therapy, and as well as cognitive behavioral therapy. And just like to thank my collaborators and acknowledge my support. The studies were supported by largely by NINDS. And then huge thanks to our group, especially to my colleague Chris King, who's a co-investigator on basically everything that I do, and he really keeps me in line, and our research assistants and such. So anyway, thank you very much.
All right, thank you so much. Oh, we got a hand. It's like we have to have questions because I'm not smart enough to come up with questions on this.
Hi, thank you. That was great. Question related to the recruitment of patients with neurologic diagnoses. A lot of them, you know, after injury are using their body less, using the affected parts less, right? And ASIA A complete spinal cord injury is not going to be using their lower extremities at all. There may be some passive loading in a standing frame. So I would expect a more ambiguous body schema in those individuals by virtue of the disuse. So how can you differentiate that factor of a more, you know, amorphic body schema and a larger receptive field being seen related to an injection of something?
Mm-hmm. Yeah, no, I think that's a really interesting question. I chose to talk about that paper in part because the spinal cord was cut, so it eliminated any kind of top-down influences. So that indicates that the spinal cord by itself is responding to these changes too, so in isolation. But I think one of the things that I do think about a lot, I don't have any evidence for, but I do think a lot about is like the proprioceptive abilities of the kids that we're seeing, the chronic pain kids they're pretty messed up. And it's really interesting to speculate too that in an intact but damaged nervous system, that their spatial tuning has been disrupted. And that's something that we're actively looking at. So we're actively doing 2-point discrimination, we're doing graphesthesia, which is really fun, and we're doing that spatial summation paradigm. We don't have enough subjects run yet to have any idea of how it's breaking down, but I can say there are a handful that have markedly disrupted graphesthesia, which is really interesting. So, yeah.
Okay, thank you. I have a question back here.
Hi, I'm a chronic regional pain patient as well as a clinician. And I've had the first year of the pandemic at least 36 spinal procedures, including cauterizations and blocks and everything. So I'm kind of wondering, yeah, my function improved, and I'm a clinician, and I can pass every single PT test. I have a grip of 92 pounds. I baffle every PT, and they still can't figure out why I'm in pain. You know, this really spoke to me, this particular thing you just spoke of. Because it's real, it's like it just keeps making more neural pathways to create pain in. So is that like a biofeedback loop that your brain creates to just kind of put the pain somewhere else?
Excuse me. Yeah, it's a really interesting question that we're thinking a lot about in terms of, are these other pathways getting engaged as the pain is getting more entrenched? How much is a top-down influence going to be a pro-nociceptive kind of signal versus an anti-nociceptive signal? What we're seeing from the early studies of the divided attention paradigm is that the posterior parietal cortex, which has a map of the body's, processes